Greetings, everyone. This is John Burstein, the Medical Director for OEMS at the Massachusetts Department of Public Health. Given the late events and the continuing events surrounding COVID-19, I am recording a short webinar with 45 slides, mostly borrowed from Region 2, thank you very much, Region 2, to give you the protocol update that was supposed to come into effect and will indeed come into effect as of April 1st. We hope that most of you have already completed the training on this, but if you haven't, it is sufficient to just listen to this webinar, look through the slides, and discuss with your service, your medical director, and I have some addresses for questions at the end. The first slide, of course, is just the introduction. Hi, greetings, and again, thank you to Region 2. The next slide is a brief overview of the changes that we have here. You'll notice there are some new protocols. Hyperkalemia is now specifically called out as a protocol in 2.19. There is a protocol for an intubated patient. This is for use either if you've intubated the patient yourself or if you're doing an IFT or otherwise have picked up an intubated patient, perhaps at a long-term care facility. But the intent is to keep patients who are intubated comfortable. It's pretty bad to be on a vent or on a bag, especially if you're paralyzed, but even if you're not, and bucking it and fighting it. There are some clarifications to the withholding and cessation of resuscitation protocol, but it's clarification. And there's a new protocol, basics and advanced EMTs to acquire and transmit, although not interpret, ECG recordings, 12-lead ECG recordings. We've also cleaned things up a little bit, removed the PD drug reference, relabeled some of the appendices. Now, under routine patient care, there are changes that are not really changes. What you will notice is that there is new language. There is no such thing as a lift assist call. There never has been in Massachusetts regulations. As you'll see in the regulation site listed there, every time you are sent out to a call, emergency call, so 911 or equivalent, you are supposed to evaluate, treat, and transport the patient. If you are called for a lift assist, even if it's a patient who you think is a chronic, oh yeah, he just needs to get back into bed, that is still under the regulations a regular call. You have to evaluate, treat, and transport. If the patient refuses transport, and an informed refusal is documented appropriately, you don't have to transport. But otherwise, you are expected to do so. I will point out that there's very good data that lift assist calls, so to speak, are very high risk. Very large numbers of between 11 and 21% of patients do poorly after a lift assist leaves them in their house, and some of them even do die. So data that are out there, these are actually patients you should be pretty concerned about. And if they're saying we want to stay home, you actually should be arguing with them in most cases. Now, since I mentioned refusal, I do want to point out that there is a specific protocol on refusal. You have to follow the protocol. We're not really determining competence. That's something a judge calls, but you're looking for capacity. Does the patient understand what he's saying? If there is a healthcare proxy on site, that healthcare proxy can refuse care if they have the actual documentation in their hand to say so. That is not exactly straightforward. We'll come back to that a little bit later. Decide that a patient has capacity and is refusing, you still need to do an assessment as much as the patient will permit you to do, because you need to establish that they're not hypoxic, they're not hypotensive, that they have a normal neurologic status, all things that actually should have been done before you even decided they have capacity, although most of us start by just talking to them and seeing if they understand what they're saying. You're supposed to explain what the refusal might mean and get a signature. Now, the signature requirement has changed in the age of COVID-19. As you'll note in the emergency protocol change earlier this week, it is permissible to take a verbal refusal, document it, and not have the patient actually sign and mess up your Toughbook or other device. That's really just for when there's an issue of infection. in any case, the documentation is more important than the actual signature. A trip record that does not have any discussion of the patient understanding the risks, or even what the risks were, even a sentence. I understand that if we leave him at home, he may have trouble breathing, lack of oxygen to his blood and organs, and he may die. And he understood this. A single sentence is better than a signature. The signature alone only proves that you stuffed something in front of the patient and he signed it. So please explain and document. If it isn't documented, unfortunately or fortunately, it isn't done in the eyes of the regulatory apparatus. I will also make the point, this is nothing new either, but in relation to the concept of lift assists and refusals, you always do have to create a trip record. The trip record is a record of the run, not of that particular patient's care. So if you're called for standby at a fire ground, you do a trip record. It says, standby at fire ground. It goes into matrix. If you're called for a so-called lift assist, you document patient fell or patient too weak to get up. That's the chief complaint. You then have to document what evaluation you did, your thought process, whether the patient refused, and if so, what made you think they had capacity or lacked capacity. When in doubt, always get online medical control involved on the recorded line. It does help. But trip records are required. And I will also point out again from the regulations, which if you want to read, they're actually on the OEMS website. Fascinating reading. I perhaps digressed a bit. You will find that you need to keep the originals, and a copy has to be delivered to the healthcare facility. Obviously, if there is no transport, your service keeps the originals and they need to be available. Continuing on our theme of changes in 1.0, remember this was all in 1.0 routine patient care. Let's get back to vascular access, a different section of 1.0. There is a new allowance for accessing a central catheter as before, but now also tunneled or non-tunneled externally accessible central catheters. In other words, anything that isn't buried under the skin with a reservoir. So if someone has a Hickman, theoretically a Quinton catheter for dialysis, although one would wonder why someone's home with that, a regular central line, a PIC, paramedic level providers who are trained to manage these lines, who will not contaminate them or otherwise wreck them, are allowed to, in the case of a cardiac arrest, just access the line, but otherwise if they vascular access in a sick patient, can contact online medical control for permission to access. Since the field is a dirtier environment than the ED, and of course the ED is a much dirtier environment than the rest of the hospital, there are reasons you might want to defer access. If you're a minute or two away from a hospital, it may not be the best thing to rush stuff into the patient. But if you're 5 or 10 or 20 minutes away, it might make sense in a patient who's quite sick or has dysrhythmias or is seizing or whatever to establish access through a central catheter if you're a trained paramedic. Going back to continuing through routine patient care, this is again a recap that you have to do a patient care report under the regs. I know. Under the fourth change in routine patient care, and this is indeed the last one, note that pediatric airways are really difficult. A lot of people think, hey, I'm great at this, I can do it. Doctors, medics, everybody. It turns out that unless you do them very frequently, it is a lot harder than you might think to intubate that kid, the first kid you've seen in 6 months or whatever in a year. So unless you are comfortable with your skill level, really comfortable with your skill level, there's good data in the literature that patients will live more often if you manage their airways with either an SGA or rather than trying to intubate them with the attendant hypoxia and other issues that may occur. So think carefully. Ask yourself if you really are as good as you think you are. We all should be at that every day anyway. I certainly do. And if you think you're that good, by all means, use your skills. If you're not sure, do what's safer for the patient. This is mentioned in all of the pediatric protocols where children may need to be intubated. In 1.1, high-quality CPR, we have changed things to try to be in concert with ILCOR AHA recommendations, of course, being the scientific body, AHA being the one that develops protocols and procedures from it for ACLS and BCLS. First of all, they've now gone back to a ventilation model of resuscitation during the first 8 minutes. Unless you are using a care bundle that you've been well trained to use and everyone does the same thing, this is high performance CPR, choreographed CPR, various different names for CR. If you're still doing that and you're not ventilating for the first 8 minutes and your medical director is aware of and has trained you in this and accepts this model, you can continue to do so. Otherwise, we do expect BVM ventilation. I will mention here, and I'll probably mention again, that really what we expect is that everybody keeps up to date with what ILCOR and AHA, specifically AHA, is really recommending and follows the most up-to-date recommendations that are available, even if the protocols have lagged. The protocols do change, but not nearly as fast sometimes as AHA protocols. So please go with what is most up-to-date as your medical director has trained you. And if it doesn't quite match the protocols, we actually do have a sentence in 1.0 saying that you need to follow what is most up to date, so you're okay. Always do what's best for the patient. Moving along, I had mentioned we took away the PD drug reference. PD doses for naloxone are now in the actual protocols for poisoning and substance abuse. So you'll see little teddy bears and a PD marker, that's the PD dose. We've also added it to other sections as well. In seizures for adults, magnesium sulfate in the seizure protocol was actually under medical control options. For those circumstances where you didn't think the patient was pregnant, started treating with midazolam, and then said, wait a minute, maybe this person's pregnant, and you were asked to call medical control to discuss your suspicions. Why do you think this person who you didn't initially think was pregnant really might be? Why might this be eclampsia? Rather than go through that rigmarole, since magnesium sulfate is standing order, if you start off looking at someone and say, oh, they're pregnant and they're seizing, it must be eclampsia, we've moved the magnesium sulfate into standing orders. Remember that it is for eclampsia, it doesn't do much for regular seizures. In the stroke protocol, we've changed the language a little bit to follow what the American Stroke Association and AHA recommend. So it is last time known well rather than onset of symptoms, clarifying wake-up strokes, and remind everyone to use stroke alert when you're calling in so the hospital is aware. Most hospitals should at this point understand exactly what that means. I mentioned there was a new protocol for hyperkalemia. It's not terribly complicated if you have already learned how to treat hyperkalemia, which one hopes you probably have at some point, but we're putting it in one specific place, calcium chloride or calcium gluconate, nebulized albuterol. Bicarbonate may have a role, but it's not clear that it does immediately in the field. And medical control can always give you orders for additional doses of calcium. In that protocol, we do give examples of what a 12-lead or a monitor strip might look like with hyperkalemia. Again, if you have questions, please refer to your medical director and ask them. They'll be sure I'm sure they'd be happy to help you. I'm also happy to if you reach out to me. We do have another page with pearls that summarizes some of the effects of hyperkalemia, but again, a lot of this is just summary. The protocols are really intended as treatment, not as a textbook. As another new protocol, and again, not as complicated as you might think, but you've got to think through what you're trying to do. There are now patients who are doing unattended, in other words, solo home hemodialysis. Home hemodialysis means you're plugging your blood access device, shunt, or perhaps a central line, into a dialysis machine, and it is running your blood through the machine, filtering it, and putting it back in you. High volume blood flow through those tubes. Typically, if someone like that were getting sick, first of all, they'd likely be in a dialysis center where the nurses could detach them. If not, if they were doing it at home, there was a requirement previously that they have a nurse or a trained provider of some kind, perhaps a family member who would be able to detach them. So call the ambulance to start detaching the patient. Nowadays, with people doing solo home dialysis, since CMS, the feds have permitted this, it becomes a little more tricky. you will see a device. You may be called by a patient or by a family member on the phone or something who is not at the site. The patient will be unresponsive when you arrive. Break the door down, go in, you'll see a box. Looks something like the picture here. They have stop buttons clearly marked on most of them. They should. You have to be careful not to just pull these lines right out. If you pull out lines that are accessing an AV fistula, they will bleed. The person will bleed like wild from the fistula. Blood will pour on the floor from the lines. If you know how to use HD shunt clamps, and you know how to pull these, and some of you may know this, then it's okay to do so. But if you don't have shunt clamps, they're not hanging on the patient's machine, or if you don't know exactly how to use them and have experience with it, what you should do is shut off the machine, shut off the 4 roller clamps, detach the tubing at the little caps, put on caps to seal up the tubing so it doesn't get contaminated, wrap the lines gently against the arm with some gauze, and go to the hospital. Leave the machine at home. If you accidentally pull a needle out of the fistula, you don't have shunt clamps, or you don't know how to use shunt clamps, you got to squeeze with your hands, not a pressure dressing, squeeze with your hands right at that bleeding point for 20 minutes. So depending on the patient's problem, usually you would be talking now about a patient who is sufficiently non-responsive by the time you get there that they couldn't disconnect themselves, which is what they normally would do. You probably will need help. Feel free to call back up because your hand is going to be busy holding that bleeding point. If the patient is otherwise disconnected and ready to move and you accidentally pull the needle out, sure, slam your hand down 20 minutes while you're rolling to the hospital, pressure right on the fistula to prevent bleeding. Otherwise, people can easily bleed out on the floor of the ambulance. Bad for the patient, bad for the ambulance. So in and of itself, not a particularly difficult concept, but the mechanics of doing it, none of us are particularly used to. There are some pictures in the protocols. You can find perhaps YouTube videos or get training from your affiliate hospital medical director or the hospitals you often transport to. Dialysis nurses will likely be happy to show you how to do this quickly and safely if you can't find any other training anywhere. This is also a fairly rare issue, so with luck you will not run into too many people with this issue. Under atrial fibrillation and flutter, metoprolol was under the paramedic medical control options section. It's now moved into a standing order if the patient's already taking a beta blocker, atenolol, metoprolol, any of the others, because sometimes it works quite well. So you have a choice. And I'll mention now and probably recap later, standing order really means standing permission. You don't have to give everything under the standing orders. You give what's appropriate. Your medical care professionals, you can decide what is appropriate, give that care. And on that subject, in pediatric bradycardia and pediatric asystolic arrest, transcutaneous pacing is listed as a standing order. Now, if you look at APLS or PALS, you will find that pacing is indeed listed as something you should try in bradycardia. It is not recommended for cardiac arrest, the reason being it doesn't seem to be effective. Asystolic kids usually, sadly, are unsalvageable because the arrest started as a respiratory arrest. By the time you see asystole, they are not resuscitatable, although we always try, or almost always try. But by putting transcutaneous pacing into the standing order box, it doesn't contradict PALS. It merely gives you permission to try it if you wish, if you think it might help, without committing a protocol violation. So epinephrine is probably still the treatment of choice. Try IV epinephrine repeatedly. If you want to try pacing in a pediatric asystolic or PEA arrest, you can without worrying that you're going to be brought up on a compliance issue. Don't expect that it's going to help. Pediatric bradycardia, it probably does help, though. Please and continue to know how to do so. On the subject of cardiac arrest, let's move to adult. We've changed the wording a little bit to indicate that you should use the right energy based on ACLS guidelines. Remember I mentioned before, whatever AHA and ILCOR update their things to, their protocols may change at a time that the state protocols have not yet been changed. Follow what AHA is saying as the recommendation. And again, and later on in the same protocol, each shock at the energy recommended by the manufacturer for your device, monophasic, biphasic, whatever you're using, consistent with the current ACLS guidelines. We do, of course, expect you to be up to date on this. AHA ILCOR actually has now gone back to using epinephrine. For a time they had decided epinephrine might or might not be helpful. There's some data that it may result in ROSC but not improved neurologic survival. But they've now gone back to using epinephrine, so the word consider was removed from our protocols. Another example of how our protocol changes may lag theirs. Follow what AHA says about ACLS. In pediatric tachycardia, SVT specifically, we've upped the energy levels to, again, correspond with PALS. Again, if PALS is updated, follow what PALS says. We have added a new medication for children with severe head injury. And we do give some indications. Again, it's not a textbook, but in a box. What do you consider moderate to severe head injury, traumatic brain injury in kids? There's now a standing order for kids who have severe brain injury with tentorial herniation, and this is kids under 15, or Cushing's reflex, meaning bradycardia with hypertension. Consider the administration of 3% hypertonic saline in the field at the dose noted. Hypertonic saline may reduce brain swelling a little. There's data that in adults it doesn't seem to make a difference, but in children it might. It's not likely to hurt them. It is simply a fluid bolus. So in effect, you're giving a traumatized child a fluid bolus, but in a form that will not decrease brain swelling. So that's something new to learn. If you are dealing with intubated patients, you'll now see there is a specific protocol that asks you to get them down to RAS -2 and tells you what that means with specific medications. Generally, start with fentanyl in case they're in pain. A tube in the throat does hurt. I can tell you that from personal experience, having woken up once with a tube in my trachea. It was not pleasant. But then after that, midazolam or ketamine may be used. Remember that midazolam does effectively prevent a good neurologic exam if you give it in high enough doses, and can't be as easily reversed as fentanyl. If you try to reverse midazolam with Reversed, can actually cause seizures. Fentanyl is a little easier to reverse. So lean toward fentanyl first and then ketamine, unless there are reasons you want to particularly give a benzo, such as seizures. EMT basic check and inject has changed from every 3-month training to every 6-month training. People have done well. We haven't found any errors. We'll keep track. There has been a slight change in the formatting 6.11, which is a new protocol, but it is not a new protocol. This is simply a protocol that calls out as a medical director option, which is what the 6-point-whatever section is, that if a medical director approves cessation of resuscitation after a 20-minute run in the field, then it can be done. Previously, protocol, but some medical directors were not aware that they had to actively opt in for this, so we've moved the language into 6.11. If your medical director gives you the okay and you get an online order and otherwise follow the protocol as listed, that is what allows you to terminate in the field. And that assumes, of course, that your system has a way to deal with that. Leaving someone who is dead in the field requires certain follow-ons for the family and for the body. I mentioned the new protocol about 12-lead ECG. That's in 6.12 that allows basics and advanced to acquire and transmit. In theory, and hopefully in practice, that will mean that if the transmission is timely enough, the online medical control physician can actually tell you what to do in relation to that EKG, including STEMI point of entry, treating hyperkalemia, things like that. And we do have fairly specific instructions on how to acquire a 12-lead ECG, but we hope, of course, that you will be trained by your medical director in service. In fact, you have to be. Mentioning again, resuscitation, now we're into 7.7, just walking through the protocols. Exceptions to an initiation of resuscitation, you have to either have a current valid DNR, verified with a MOLST, or, again, I mentioned a healthcare agent who is the proxy, who is on scene and has the proxy document in hand. We can't, by regulation or law, and it is not an OEMS regulation or law, except someone who says, I'm the proxy, oh, I forgot the piece of paper, I'm his wife, but I have no piece of paper and I've never been formally named the proxy. They've got to be formally named as a proxy and have the documentation, or there has to be a filled out and appropriately signed MOLST. And if you're having issues with this with particular patients, families, or medical systems, the answer probably is for your affiliate hospital medical director to approach that patient's PCP, who can get them to do a MOLST, or approach the hospital system. And I am happy to help out if that's an issue. Just ask the medical director to get in touch with me, and I will certainly try to mediate and help. And again, 7.7 now calls back to 6.11, the new option protocol that says if your medical director does has chosen the option to cease resuscitation after a 20-minute attempt, then it's okay. Just makes it clear that the medical director has to choose that for the service. It is not an individual online medical control physician function. In the fire and tactical rehab section, first of all, we left D off the slide, and I apologize, but we just changed the blood pressures to match the new NFPA numbers. If those change again rapidly in the future and we can't keep up, follow the new numbers. Remove the pediatric med reference. The reason for that is that it was very hard to actually keep it up to date and accurate. And most people use tapes or phone-based apps or some other system, which is appropriate and recommended practice. Please continue to do so. You should not be relying on a reference in the back of a protocol book for this in the modern day and age. We did put the pediatric doses, various protocols, of course. We did renumber them reading appendices to make everybody happy. So we have med reference because of the new protocol, hypertonic saline calcium gluconate, although note hypertonic saline really is only for 15 and younger. We did add in scope of practice the acquisition and transmission of 12-lead ECGs. And that's pretty much it. If you have any questions, there are 3 emails you're welcome to send emails to, and we will get back to you fairly rapidly. If we don't, you can always call us at the OEMS phone number on the web, and we would be happy to help out. I'm happy to deliver similar talks as much as I can, given what's going on lately. Obviously can't meet face-to-face for most of this, but we want you to make sure that you're comfortable with the new protocols. And we would like to thank you for all the work you're doing, especially nowadays where things really are getting complicated, but we will get through this. And remember to wash your hands, wear your PPE, stay safe, and be careful out there. Thank you very much.